Our next speaker is Dr. Lori Klotz, who's going to talk about the genomics and natural history of MRI-invisible cancers. One of the very first papers my group wrote when we started working on imaging was morphologic comparisons between what you see and don't see on the MRI. And it's interesting that 15 years later, this is still the most, in my opinion, critical question that sits at the core of focal therapy, whether what you don't see is irrelevant. And so Dr. Klotz is going to update us on how far we've come with this topic.
I think you're saying there's nothing new under the sun, which could be. And this is really a conceptual talk, nothing to do with regulatory. My disclosures, I got research support from Exact Imaging, who make the microultrasound, from Profound and Tulsa, and from peer review agencies supporting some of the clinical trials I led in this area. So I'm going to start with the take-home message. So you can then, digest your lunch after this. The take-home message is recent radiogenomic studies demonstrate that the genetic alterations associated with MR visibility are the same genes associated with cancer aggressivity, invasion, and metastasis. And invisible cancers lack these. The benign genetics of MR-invisible cancers are associated with an indolent natural history. I'll show some of that data. The point is to move beyond the rubric of, there's grade group 2 or greater being clinically significant. And these invisible cancers pose little threat. We should look for them. We shouldn't diagnose them. This is the concept of image-guided management. And just to finish with a caveat that this is a guideline and a concept rather than a rule, there are exceptions. So just a little background on this issue of invisible cancers. There's many studies that have compared targeted to systematic. This was a systematic review a few years ago of about 12 studies that show on the right systematic, the middle is targeted, the left-hand bar is total, and overall, roughly 15 to 20% of men having systematic plus targeted will have only positive biopsy on the systematic, and that is grade group 2 or higher, so-called clinically significant. So the concern about these invisible cancers drives a lot of interventions. It drives systematic biopsies, and men having targeted biopsies means these guys are getting 12 to 16 cores instead of 3 to 6. It drives systematic biopsies in men with negative imaging. That is still quite a widespread standard of care. And again, 12 to 16 cores versus no cores. It results in a lot of pushback on the concept of focal therapy, totally relevant to our meeting here. And the pushback is, prostate cancer is multifocal. This concept of focal therapy for a multifocal disease doesn't make sense. And it drives a lot of patient anxiety in men on surveillance. They know there's a chance that they have a clinically significant cancer that they don't know about, hasn't been diagnosed yet. Is this going to be a problem? What's the biologic significance of these non-visible cancers? So visibility is a function of two things, size and conspicuity. Obviously size, very small lesions are less likely to be seen. It gets more interesting with respect to conspicuousness. So that's determined by the tightness of cellular packing, the quality of the lumen. The major difference between Gleason pattern 3, 4, and 5 is the quality of the lumen. That correlates with the grade. There's some types possibly associated with lower conspicuity, like mucinous adenocarcinoma of the prostate, but these are uncommon. And the point is that the invisible cancer, that invisibility is a marker for favorable genetics and biology. I'm going to go through that in a moment. And the implication is so-called image-based management. Don't worry about what you can't see. So first, just a little overview of really what's becoming a tsunami of radiogenomics papers. And the first paper that I know of was 2018, but most of what I'm going to present is just in the last 2 to 3 years. This field is on fire. It's basically a combination of pixel analysis of MRI. A lot of it uses AI. and integrating that with the gene expression as well as pathology and clinical outcomes. So there's a 4-step process. I'm not going to go into too much detail, just to say there's many ways of analyzing MRI at a very granular level that's actually a lot different from what we do in the clinic, where you're kind of looking at the 3 parameters and finding the cancer. It involves really detailed analysis. And then you integrate that step 5 with gene expression profile. So I'm going to show some of this, just bear with me. This is a sample of about 5 or 6 different radiogenomic studies, and the point is they all show the same thing, which is that the invisible cancers don't have the genetic alterations, and the visible cancers by and large have the genetic alterations that we associate with cancer aggressivity. So this I think is the best one. This was published about a year ago from Scandinavia. Histomic and transcriptomic features of MR-visible versus invisible associated with prognosis. There's hierarchical clustering by visibility. There's a volcano plot on the bottom right, essentially showing the distribution of differentially expressed genes between visible and invisible, very different. And this is from the same paper, the most significant upregulated pathways. And for those of you who have an oncology background, the molecular genetic alterations are very familiar looking genes. Cell cycle regulatory genes, methylation related genes, interleukin and signaling related genes, cell adhesion molecule related genes, the genes that we associated with more aggressive cancers, increased proliferation, inflammation, regulation of transcription. And the conclusion, sampling MRI-visible lesions with target biopsy should be sufficient because the cancers you're missing lack genes of aggressivity. This is the first one that I'm aware of, 2018. They mainly looked at a family of 4 genes, but you see the families of genes: mitotic cell cycle, protein folding, mitosis regulation, the ones that are increased and the ones that are decreased in visible versus invisible. And the more recent studies really go a lot further. This is transcriptomics. On the right, you see different ways of analyzing the MRI, and there's like 30 of these, all very kind of AI-assisted and granular. And on the bottom, you see some of the familiar-looking genes: ERG, EGF receptor, STAT6, so well-known genes associated with aggressivity. They disaggregate. This one is hypoxia-related genes, and again, a long list of the different MRI features. Kurtosis, a lot of them measure some aspect of kurtosis, which refers to kind of granularity of the image at a very fine level. And again, you can see these hypoxia-related genes disaggregate according to these various MR features. This is a term that coined, I believe, by the UCLA group called nimbosis. Nimbus clouds are storm clouds. So nimbosis, a gathering of stormy clouds, meaning all the adverse clinical, molecular, pathologic features of aggressive cancers: genomic instability, hypoxia, clinical aggressivity, a confluence of aggressive molecular alterations. And sure enough, the features of nimbosis, this comes from Rob Reiter and paper, SHLAP1, known oncogene. PGA stands for percentage of the genome altered, which is kind of a global assessment of genetic alterations, hypoxia-related genes. And you can see this is visible versus invisible, PIRADS 1 to 2 versus 4 and 5, and really pretty decent separation. There's the ROC curve for predicting adverse outcome. Here's one more. This is proteomics. So it's just these radiogenomics look at genomics, proteomics, transcriptomics, et cetera. This was mainly stromal alterations, and again, the same story, alteration in genes affecting stromal proliferation associated with cancer visibility. This one had a actual clinical endpoint as well, showing that visible versus invisible dramatically or fairly substantially influenced outcome. So that's kind of an overview. There's more for those who are interested. There's about, I would say, 20 papers in the literature now that look at some aspect of radiogenomics, gene expression, and MR visibility. And then here's the clinical data. And this is, I think, a phenomenal paper from Sloan Kettering, Wibmer, 1,449 men having surgery for clinically significant grade group 2 or higher prostate cancer. And if you look at the bottom left, for example, prostate cancer-specific mortality, the red is the PIRADS 4-5, the green is the PIRADS 1-2. Essentially no postoperative deaths, no deaths post-prostatectomy with the invisible cancers, and almost no biochemical recurrence. Remarkable separation of the curve just based on visibility. This is an active surveillance one, same kind of story. Visible versus invisible, really stratified according to the risk of this was upgrading and time to treatment. This is our recent data from our large surveillance cohort. We are now getting up to close to 25 years follow-up. And just 2 observations from this cohort. This is submitted for publication. I hope it'll be published soon. The first thing is that we disaggregated according to pre and post MRI era. So overall, we have one of the higher prostate cancer metastasis and mortality rates in the literature because we were very inclusive, particularly for the first 10 years or so. So we have about a 3% prostate cancer mortality overall, a little higher when you get out to over 20 years, but not many patients. But when you disaggregate according to the MRI era, which was 2013, before or after, we have not had a single patient progress to metastatic disease in the cohort that started having their MRIs in 2013. Just, you might wonder, how could we have 20-year follow-up if it only began in 2013? Because some of these patients were diagnosed earlier and then included started having their MRIs a few years after they were diagnosed. So the MRI in the active surveillance protocol really makes a difference. That's the first observation. But then we just looked back at MR visibility versus invisibility. So these patients, for the first 10 or 15 years, all had systematic biopsies, targeted biopsies after 2013. This compares the outcome in the invisible versus visible. And the striking thing is 5% of the cases with invisible cancers were upgraded by around 10 years, 5% versus 52% with the visible cancers. So this really supports this idea that the invisible cancers are incredibly indolent. And this is the Kaplan-Meier, so the blue line is PIRADS 1-2, the red line is 4-5, the green line is in the middle. We only had a handful of patients who were upgraded with invisible cancers. They were right at the beginning. And that was kind of early in the MRI era. I have a feeling those two probably had visible lesions that were just missed. So virtually no patients upgraded. One of the issues that's been put out there is that cribriform cancers are more likely to be invisible, which would undermine this whole hypothesis, because cribriform is bad news. We looked at that in one of the randomized trials we had in Canada, the PRECISE study, which was the Canadian version of Precision, 453 men randomized between systematic and targeted only, and didn't make a difference. The cribriform was actually more likely to be visible than the patients who didn't have the adverse variants, so that doesn't seem to be an issue. The other side of this coin, sure you've all heard about this, is starting with the audacious group led by Meissner, 25 cases, positive MRI, positive PSMA, radical prostatectomy with no biopsy. Gutsy maneuver. 100% of the patients had grade group 2 or higher. And now there's a couple other papers starting to get up there. 50 cases from Munich, 47 from Beijing, 100% grade group 2 or higher, 100% grade group 2, 100% grade group 2 or higher, all 3 papers. So, boy, there's a message there that if MRI and PSMA are positive, that really is very strong evidence of significant cancer. Just some other thoughts about what it means to have positive, systematic, negative, targeted. Some of this is off-target biopsies, especially for people on the learning curve of targeted biopsies with fusion targeting, where there's a lot of potential pitfalls. And there's quite a bit of evidence that, for example, that scenario, positive, systematic, negative target, it's almost always ipsilateral to the target. It's almost always in the same region. It's probably an off-target biopsy. Another point I just want to make is about the improvement in MRI. So this is a rapidly evolving field. First of all, AI. Here's just some data. I'm getting ahead of myself. Here's some data that what I just mentioned, that the ipsilateral systematic biopsy finds the significant cancer in 96%. The contralateral biopsy really hardly adds anything. This is the AI story. So this is from a few years ago, and it's gotten better since then. This is the ROC curve for the accuracy of MRI for the presence of Gleason 4 pattern. The blue is experienced radiologists, the blue star. The blue line is AI. So, in this study, AI did it significantly better than experienced radiologists, and that obviously is coming. And then there's all these techniques to enhance MR, about 8 or 9 of them. Again, this is more sophisticated ways to look at the image, and this also, I think, is going to enhance the accuracy of MRI. This is just one example, restriction spectrum imaging, where ADC was equivocal, and there was a very clear pattern on this restriction spectrum imaging technique. So again, this is just another example of how we can look forward to getting better information about the cancer from the image. And then another question is, so MR, we have radiogenomics. There's essentially no data on the ultrasound genomics. It's probably a better term for it, but the genomics of visible versus invisible in ultrasound and PSMA. PSMA, obviously, it's PSMA expression. It's a more kind of unifocal phenomenon, but there may be something to learn there too. This is the only paper that I know of on the so-called, it's not radiogenomic, but ultrasound genomic analysis of ultrasound phenotypic features with proteomic analysis, 17 imaging features, and basically the same story. Ultrasound phenotypic features associated with increased expression of metastasis-associated genes. So this is, I would say, a fairly new concept. Certainly the radiogenomic story is really unfolding as we speak, just the last few years. There's some unmet needs in this area. Part of the assumption is that there's going to be these small, higher grade tumors that are missed, that you can follow the patient, you re-image, the lesion is now larger, you see it, you treat it in time, and the patient's still curable. So I think we all hope that's true, but we need to demonstrate that it's true. We need more radiogenomic studies. We need to interrogate existing databases. Think about what we could do, for example, with the Prius study that has 10,000 patients, mainly in Europe, for better data on the natural history of visible versus invisible cancers. I showed our cohort, but that would benefit from other similar studies. PIRADS3 is an issue. In our data, PIRADS3 behaved more like PIRADS4-5, but this is, also one of the uncertainties. And the other side of this coin, so this is something that I really grapple with. You have a PIRADS5 lesion, the biopsy shows grade group 1. You rebiopsy, it's still grade group 1. If this story is correct, if you believe the radiogenomics, then those grade group 1 cancers may be the ones that harbor the aggressive genetic alterations. Maybe they should be treated. I haven't started doing that yet, but I know some people are moving in that direction. I just heard there's a randomized trial that's been completed of focal therapy versus surveillance for grade group 1 with positive imaging, which kind of is pursuing this idea. So, great insights in history, the wheel, Pythagoras, planets orbiting the sun, Heisenberg, MR cancer visibility determined by genetic alterations associated with cancer aggressivity. Invisible cancers lack these alterations. There's obviously a little tongue-in-cheek, but I think this is really a very powerful new idea that is supported both by a number of genetic studies and now increasingly by clinical trials. I've had 2 recent publications on this. If anyone is interested in hearing the idea elaborated or reading a little more elaboration about this concept. And so to conclude, these MR-invisible lesions are different. We don't do the patient a service by saying, oh, there's grade group 4 pattern, there's pattern 4, grade group 2, it's clinically significant, they need treatment. These are really more like grade group 1 cancers if they are invisible. They pose a little threat to the patient. You follow the patient, you look for a change in the imaging. If it's there, it's another story. Patients obviously prefer monitoring with imaging to a biopsy. And this has a lot of advantages, an image-based versus a biopsy-based approach in terms of burden of care, cost, psychological benefits, adverse effects of the biopsy, less diagnosis of insignificant cancer, and so on. Thank you very much.